Good afternoon, everyone. Welcome to the 2022 Hypertension Control Summit, the Tour of Texas. This event has grown exponentially since year one of this joint AHA, DSHS, AMA effort in Houston to a statewide event in year two to now a virtual series in the last 3 years. This movement has become stronger due to the ongoing commitment of leaders and organizations such as yourself, and our relationships have grown deeper due to the participation of everyone on this call today. We are grateful to have you. We want to welcome you, including all of you who might be on the journey for the first time with us, and those who have continued to return year after year. My name is Jenny Iyer, and I'll be serving as your MC today, your driver, your tour guide, if you will. And it's my pleasure to be your tour guide as we travel across the state of Texas, highlighting expertise of local leaders, as well as hearing from our national voices. In my role as Vice President of Health Strategies with the American Heart Association's North Texas office, my amazing team and I have the privilege of working with clinical and community partners, a few of whom you will hear from today, to improve hypertension control across our community. On behalf of the AHA, the Texas Department of State Health Services, the AMA, and the Texas Cardiovascular Disease and Stroke Partnership, I want to thank you for being here with us today and for your ongoing efforts towards this same goal, which has motivated and engaged so many health leaders across Texas. Each of you plays a key role in reaching our goal of having greater than 70% blood pressure control. And we can do this by working together one person at a time. Just as we do before all of our big road trips, I know we have checklists. We do have a bit of housekeeping. Just want to let you know that everyone except the speakers will be muted so that we can manage our background noise today. We will be using both the Q&A and the chat function during our time today. So if you have any questions for the speakers, please use the Q&A function. If you have a question that someone else has already asked in the Q&A, you can upvote it so that it rises to the top of the pile. We will try to get to as many questions as possible today and address those that we don't address in follow-up communications or subsequent events in the Summit series. We will also be using the chat function where we will drop links to key resources and where we will ask that you now, I think I saw something come through the chat as well, to introduce yourself. We'd love to know your name, your organization, and the city and or town where you are located. This webinar is being recorded and will be posted to the 2022 Texas Hypertension Control Summit Series webpage. As a reminder, you will be seeing slides and presenters, and you can scroll that bar there on your screen. You can make the speakers bigger or the slides bigger. You can make those adjustments however you would like. And as a reminder, please keep all hands and feet inside your vehicle as we are about to begin our trip. Buckle up. So we do have a packed itinerary today, beginning with our health center features and moving into a panel Q&A. Please, again, type any questions for the speakers in that Q&A box at the bottom of your screen. We're there, we'll hear from our features. We're gonna have that Q&A, and then we're gonna have the clinical updates from Dr. Kate Curley. And then we'll close us out. And hopefully this leg of your journey will just be super wonderful and exciting. You'll take lots of pictures and make lots of memories. So as we start, we are gonna start our first stop on our road trip today is going to be in North Texas with Miss Lisa Rigby. Lisa Rigby is the executive director and a dear friend at the Woven Health Clinic, 501c3 community clinic since January 2015. Woven Health Clinic provides a medical home for low-income, uninsured adults that live in Dallas and surrounding areas. She previously served as the Senior Director of Development Operations for United Way of Dallas for 4 years. In addition to nonprofits, she has 15 years marketing and operations experience with technology companies. She has an executive MBA from the University of Texas at Dallas and a BBA from the University of North Texas. She is an advisory member for Brookhaven Community College Front Office Medical Program and currently serves as a member of the UT Southwestern Center for Mood Disorders Network. Since 2015, she has increased clinical funding from 650,000 to 2.5 million, launched an innovative integrated healthcare program focused on disease prevention, and expanded services from primary care only to include nutrition therapy and basic mental health services, with a strong emphasis on preventing diabetes and heart disease. She is passionate, as I know you will see in the next few minutes, about reinventing healthcare payment and delivery models to ensure that everyone has access to quality, affordable healthcare. So, Miss Lisa, if you can unmute yourself, I'm excited for everyone to get to hear the amazing work I know so well that you do day in and day out, and I will hand over the steering wheel to you.
Thank you, Jenny. Thank you so much. I'm so excited to be here. We have partnered with American Heart since 2017, and I'm really excited to share some of our best practices that we've worked on together. And together we've impacted over 5,000 patients in terms of lowering their blood pressure, getting their blood pressure back to normal. So this program is the hypertension algorithm. It's all based on American Heart's best practices, and I'm going to emphasize some of the things that make it unique. Part of it is team-based care. Next slide. So what is team-based care? Back in 2016, we talked about this. We wanted to implement this. Well, first it starts with what kind of team do you have? You know, in many clinics, it really is mainly the physician, nurse practitioner, nurses, and medical assistants. So what we looked at Woven Health is who do we need to complete our team? And we added a registered dietitian and a behavioral health specialist. And these positions are really critical, especially for our hypertension algorithm. So it starts our day every morning at 8:30 to 9 o'clock. We have a quick huddle, and all of our clinical team members are required to be on that quick huddle. It really starts the day before, looking at the patients that are coming in, which ones have hypertension, which ones maybe have pre-hypertension, who's diabetic, who needs to see a mental health counselor. So we go in and look at the lab work, and those notes are made. So in the morning, we take each patient and do a very quick summary to highlight who we need to see, and it's specifically for the hypertension algorithm. Which patients are we going to focus on? What ones do we need to see, and what do they need from us? So next slide. The goal of our hypertension algorithm is that we want to prevent or control stage 2 hypertension. And so what that really means, you know, we were seeing a lot of patients that would come in with elevated stage 1, and, you know, shortly within the next 12 to 18 months, they would move to stage 2, full-blown hypertension, and be on meds. So we started identifying these patients when they come in. So you're going to see that the goal of our program is to reduce their risk factors. So we look at that blood pressure when they first come in. Where does it fall in the category? Normal, elevated, stage 1, stage 2. Fortunately, we don't see a lot of hypertensive crisis, but it's really focused on where do they come in and trying to lower their risk. So when you hear me talk about those categories, these are the metrics that we're using. These are the ranges that we use to put them in that category. Next chart. So our protocol for this starts with the medical assistant or nurse. When our patients come in, we do a lot of screening and questionnaires. So we ask them about their alcohol intake. We want to know if they're a smoker. We take their blood pressure. So we take all of these factors in their social history, and then based on where their blood pressure is. So looking at that reading, are they normal, elevated, stage 1, or stage 2? So let's start with the stage 2. If they're stage 2, they may have a diagnosis for stage 2 hypertension. The provider is definitely going to be giving that patient medications. So that is one of the unique things. They'll talk to them about the dangers, particularly if they go off their meds, the fact that, you know, if they go into hypertensive crisis, what the dangers of that are. We actually have an infographic handout that every patient that's diagnosed with stage 2 gets. And we have managed, we started doing this small education infographic tool about 4 years ago, and it literally reduced the percentage of patients that we had in hypertensive crisis by 75%. It was shocking to me, a little basic education tool for every one of those, a reminder how important it is to take your medication, and if you run out, to call and we'll extend it. That made a huge, huge difference. Let's go over, if you're normal, we don't worry about that, at least not right now. No further action required. The ones we really do a lot of focus is elevated and stage 1. So we talked to them about the fact that it could progress to full-blown stage 2 hypertension. We also talked to them about a treatment plan. And that treatment plan starts with making sure we give them a home blood pressure monitor. We train them on how to use it, how to take their blood pressure, and how to track it. So that is really the heart of this program. Along with, they see a registered dietitian. Our dietitian uses the DASH diet, and they'll receive 3 to 6 nutrition counseling sessions, education on implementing the DASH diet. We give them the cookbook in English or Spanish. And then also, if stress is a problem for them, they'll see our behavioral health counselor to talk about lowering the stress. If they're a smoker, we put a tobacco cessation plan in place. And then we also, after that, we schedule the next appointment. So they may come back in 1 month. If they're new or uncontrolled, they'll be back in a month. Once they get it under control, the treatment plan is working, we'll see them every 3 months. Next. This is our Heart Healthy Kit. So every patient that is elevated stage 1 or stage 2 that comes into our clinic gets this Heart Healthy Kit. So you see there is a blood pressure monitor. That's a home blood pressure monitor that goes home with them. They're trained to use it. The DASH diet cookbook, in addition to meeting with the registered dietitian, they will get that cookbook. We actually give them a lunchbox to take their lunch. We want to encourage them to take their lunch. And you see the plate there, that plate really talks about portion control. It actually shows, it's embossed with the largest portion is supposed to, of course, be your vegetables, your fruits and vegetables. It shows you the portion for your protein and the portion for your grain. So this kit goes to every patient with elevated stage 1 or stage 2. Next slide. We also spend time to teach them. So our nurse or medical assistants will actually take 5 to 10 minutes to go through how they need to take their blood pressure, the proper way to do it, and to make sure that they're either bringing that in, it will store it on the blood pressure monitor, or keeping a blood pressure log that they can share with us when they come back for their next appointment. Next. One of the unique things we do through American Heart and our collaboration is healthy cooking classes. So pre-COVID, we have a full kitchen. We would have about 25 to 30 patients that would come in. Chef Walter speaks Spanish, and he would come in and do the entire cooking demonstration in Spanish. We would also give each patient groceries and the recipe so they can take it home and cook it for their family. You know, we wondered, would this really work? It has worked phenomenally. Our patients want to know how to cook healthy, and your diet makes such a difference in your overall health, especially for hypertension. So this has been very successful. During COVID, we had to move it to virtual cooking classes, and we have had some success with that. And going forward, we're going to do both the virtual and the on-site. Next slide. We also bring in exercise. So if they're not exercising at all, we'll start with maybe 5-10 minutes of walking. We actually do free walks 2 to 3 times a year. We invite our patients to meet at a park, and we have some of our clinical staff, sometimes our physician, nurse practitioner, RD, we rotate a variety. They show up, and we do drawings for free health giveaways before the walk starts. And then we just do a walk. And it does 2 things. It's good for your health, it's good for your heart, and it's also good for your mental health. We've done free Zumba classes. We have a patient that we've hired to come in and do free Zumba. We've done yoga and mindfulness classes. So we really try to make sure that we give our patients opportunities to get moving. Next slide. These are just some pictures. You can see some of the events that we've done. And we really get great participation from our patients. And we really feel like it makes a big difference to engage them in both the nutrition, the exercise, and the mindfulness to lower their stress. Let's go to that next slide. So how do we do this? When they meet with our registered dietitian, our physician, nurse practitioner, behavioral health, we actually set goals. So there is a plan. It might be you'll have one plan with our registered dietitian focused around nutrition and your nutrition goals. You could have a plan focused around our physician and nurse practitioner that's about taking your medications, getting your lab work done, coming back to your next appointment. You may have a plan for your mental health with our behavioral health specialist. How are you going to quit smoking? A tobacco cessation plan. How are you going to lower your stress levels? So it's quite frequent for our patients to have 1 to 3 plans. They're small goals. We don't give them big goals. Like, for example, if they're drinking a lot of soda, 3 or 4 a day, we'll ask them to reduce that by maybe 1 or 2 to their next visit. So we try to get them to maybe exercise 10 minutes, very small goals that we know they can accomplish. Next slide. This is just another one. We have one for exercise, so it could be nutrition or exercise. And part of this is asking them to identify the barriers and think of strategies that they can overcome it. Let's go to the next slide. So we want to measure the success. All of these things that are in our algorithm sound great, but how do we know they work? And so we thought about our goal is to reduce the risk factor. So what we do, this particular time frame was June to May. We can change the time frame. It can be January to December, whatever time frame we're looking for a measurement period. We look at when they first come in, what's their first blood pressure reading? Where does it fall? What category? Is it normal, elevated, stage 1, stage 2, or uncontrolled? And then we look at the end of the measurement period, what happened? Did it go up or down a category? So this is what this chart shows. So we'll start on the left with stage 2. So during this time period, 83% of our patients actually reduced their risk factor. They went from stage 2 either to stage 1, elevated, or normal. And if you look at stage 1, it drops a little bit. We had 63% of our patients that actually went to elevated or normal. So as you move to the right, it does get harder to lower that, but it's still worth tracking these factors because you can benchmark yourself. Unfortunately, there aren't a lot of national benchmarks for how to reduce the risk factor. So you can see on stage 1, we had 63%. You go to elevated, we had 39% that actually went from elevated to normal. And so that is really our goal. We really want to have that no lower than 30%. And then if you look at normal, we had 72% that stayed normal, which is good, and 28% that went up. And what we found by doing this is we benchmark each different time period against ourselves. And we found over the last 5 years, the percent of patients that are decreasing their risk has increased almost every year, even during COVID, which was really outstanding to us. Okay, let's go to the next chart. And this is my final chart. We do a lot of metrics to see how is this algorithm really working for our patients. So that first one is 95% of all of our patients basically get screened for blood pressure every time they come to the clinic, and we create a plan for them. Unless you're normal, you're getting a hypertension plan. So if you're elevated, stage 1, stage 2, whatever it is, if you're not normal, we're giving you that plan that we talked about. We're implementing that hypertensive algorithm for you. And then in terms of overall controlling, there are a lot of national benchmarks. So for that time period, it was 83%. I just remeasured it. That was like through the summer, through June 1st. We remeasured it through the end of last year, and that number actually jumped to 88%. So this number since COVID has been going up. in terms of control. And then preventing high blood pressure, we do have, this number is a little different. This is looking at all the patients that were elevated stage 1 and stage 2 who returned to normal, who went all the way to normal, 40%. So we really believe that this protocol has great outcomes. It's helped our patients. We see it also with other things like their diabetes and their mental health conditions. It's, we want to continue it and add to it. And I really appreciate the great support we've gotten from American Heart. They really have helped us implement this, set the best practices, and provided a lot of the support. Thank you. Next slide.
Thank you, Miss Lisa. Everyone, she is giving you a very, very good street sign to remind you that if you have questions, she's going to be back. So please write down your questions if you could. Put them in the box. Miss Lisa is going to be back on a panel with our next speakers. So please keep those questions coming. Go ahead and put them in the Q&A or be thinking of them, and we will get to those in just a second. Miss Lisa, I so appreciate you joining us today. It is just amazing to hear about the impact that your team-based care approach to manage hypertension has seen. And I love that you have the team meeting that you all do every single day, and just how much that makes care more streamlined for your patients. So appreciate you taking the time to join us. Now we have another two amazing women that are doing some wonderful work in North Texas. Ruby Camacho and Carmen Lavareda from North Texas Area Community Health Center. Miss Camacho has been a nurse for I wanted you to get to hear the sounds this time. I talked over it last time. Miss Camacho has been a nurse for 19 years, starting as an LVN, then obtaining her RN after several years. She has experience in pediatrics, outpatient services, and acute care at various healthcare systems. She loves to provide patient care, and when she is not at work, loves spending quality time with her family. A certified bilingual interpreter in Spanish, Miss Lavareda has been a nurse for 16 years. She is a nurse case manager for special programs and has experience in adult medicine, pediatrics, internal medicine, geriatrics, and infectious disease. She enjoys teaching and interacting with her patients daily. Being bilingual helps her assist her patients in navigating the often complex healthcare system. Carmen graduated from the Concord Career Institute, and in her spare time, she hikes, reads, and travels. We are so grateful to have you both here. If you can unmute yourself, I'm going to hand the steering wheel over to you so you can drive us through the great work you are doing. Over to you, Ruby. One second, we're going to pull Miss Ruby up here. In just one moment. I will take this time as we're bringing Ruby and Carmen up, just to remind you that if you haven't been able to tell us that you're here and giving us your name and your city, town, the organization that you're with, we would absolutely love to be able to have you to know that you're here, and to make sure that we knew you were on the tour bus, and that we can follow up with any other questions. It looks like we might have had some technical difficulties. Ruby's computer might have been turned off. So 1 second as we take a little detour on our road trip. We're going to take a sightseeing break for a second. And Miss Lisa, I do have a quick question for you that came in the chat that I thought you might be able to quickly answer while we're kind of bringing Ruby back into the chat. But there was a question if you could just tell a little bit about your patient population. I know you serve a pretty specific population. If you could just kind of share with them, I think you talked about it at the beginning, but maybe just a little bit more information on the patients that you're able to see and that come through your clinics.
Yes, we see, first of all, we see adults. We don't see children. So it's 18 up to about, we have some patients that are up to about 72. The average age of our patients is usually around the mid 40s. So we do have more patients 40s, 50s, 60s area. Ethnicity wise, 60% of our patients are Latino and a large percent of them speak Spanish. So all of our materials, the majority of our staff are bilingual. We have all of our materials in Spanish. It's one reason that DASH diet book was really great. We have it English and Spanish. Cooking classes were all in Spanish. And so that's pretty much the population. More women than men, not intentional. I think we just get women tend to go to the doctor more.
Thanks, Miss Lisa. I have another question for you because I'm just going to follow up on some things that I know that you have done. And thinking about your cooking classes, you've often shared with us that, you started doing them in 2 different formats, and then you realized that really only one format was working. I feel like sometimes, so many times in the community and in the clinical work, we kind of have a plan in place. And when it doesn't work, we're like, oh man, we should never do this again. But instead, you kind of pivoted a little bit. Could you share on those cooking classes that how you started it is not exactly how they look now, just because you found one population was way more excited to come than others?
Yes, it's fascinating. We started them, we'd have them in English, and then we'd have a different one in Spanish. I would get about 6 patients to my English cooking class. For some reason, a lot of my English speaking patients seem to think they know how to cook. They may not, but when we would have them in Spanish, we would literally get standing, we can only get about 30 people in that room, and we would literally have 30 people every time. So I just eventually decided we would do them in Spanish because that's where our need for our patients and that's the demand.
Thank you, Miss Lisa. I appreciate it. It's nice to always know that you can take a little bit of an adjustment when you're starting out and keep trying new things, and then being able to focus in on one where you're really reaching so many more patients. So I appreciate it. Thank you for going on this small detour with me, Miss Lisa. Thank you for taking back the steering wheel. We are now going to give it back to Ruby. Ruby, I'm going to hand it back over to you. Thank you again for joining
Technical
us.
difficulties there.
Hey, every road trip has a couple of speed bumps. Don't worry. We're getting back on course.
Of course. All right. So I'm ready. All right. So living your best life. It was already said, my name is Ruby Camacho. I am the Director of Nursing here at INTAC, and Carmen Lavaretta is the Nurse Case Manager, and she is with me on this journey today. Next slide. So the description and purpose of Living Your Best Life is a chronic disease management program developed by North Texas Area Community Health Center, also known as INTAC, whose patient population consists of predominantly uninsured individuals. The purpose of Living Your Best Life is to educate, empower, and equip patients to control their chronic conditions using an interdisciplinary team approach. And we do use the American Heart Association guidelines. If you can click so we can see our chart there. Thank you. Next slide. All right, so Living Your Best Life program services. We have case management, in which case managers will work one-on-one with patients and or the patient's caregiver to provide individualized support and tailored interventions to help patients manage their chronic illnesses by providing motivation, support, and encouragement as they address this chronic healthcare needs or lifestyle changes. In addition, the case manager will continually support ongoing communication between the patient and the healthcare team. We do health education, individualized and in group sessions. So this focuses on specific topics which are rotated as part of the education, as part of an educational series. And they include cooking and shopping, food preparation, high blood pressure diets, fitness and stress reduction, medication management, blood pressure monitoring, and then the small groups, group educations are discussed and offered by the community health care workers. Emotional and behavioral support. As we all know, many patients with a diagnosis of hypertension, a diagnosis of hypertension is accompanied by depression and anxiety over all of the implications and long-term healthcare needs that they will encounter. And this, the emotional and behavioral support is essential because patients may lack that emotional support at home from family and friends, to successfully manage their disease. And then we do screening for SDOH, which is the social determinants of health. And we use a tool to help us better understand the patient and their needs. And then we have a pharmacy consult, which helps with a medication review and communication with their primary care provider for medication management. And in addition to all of this, we do have online resources that we provide to the patients for additional support and that are pertinent to their chronic disease management. Next slide. Oh, I forgot my quote there. To change your life, change something you do daily. This is something that living your best life teaches our patients, to change your lifestyle. You need to take it one day at a time and create that change for their chronic disease management. Next slide. Criteria for enrollment. They need to be an intact patient with a diagnosis of uncontrolled hypertension or diabetes. And then they need a referral from the intact primary care provider. Exclusion from the program is chronic kidney disease. Next slide. All right, the process for enrollment into the program is we do provide an intake, which the patient, will be identified and meet the admission criteria. Case manager will receive the referral and contact the patient, and then the intake is conducted via phone call to discuss the details of the program. In this meeting, the patient is interviewed via phone call, assessing their readiness for the program. The patient is advised to think about the program as offered and to speak to family before they are officially admitted to the program. Then there's a care plan meeting that is scheduled. And so during this care plan meeting with the patient and the case manager, we review the medical case management plan, establish patient goals, and provide appropriate resources. And some of these, at this meeting, we also complete a hypertension care plan, and we initiate any electronic referrals such as iClinic, behavioral health, pharmacist, and dietitian. And then after that, the hypertensive patient is issued a Bluetooth-enabled blood pressure monitor, and they are synced, and instructions are given to the patient on how they will take their blood pressure and how the system will upload it to our system, to where our case manager can see what's going on with their blood pressure. And if there's any out of range blood pressures, there's an alert that goes off, and our case manager calls the patient to check on them. And then we do schedule follow-up medical visits with their provider, and health education is provided at that time. And also we assess the needs for medication management, and these visits are typically every 3 months or as needed. So if they need a sooner appointment than 3 months, then that is scheduled for them. And then the duration of the program is 12 months. So the patient completes the program after 12 months. And if they are needing further admission to the program, then a new referral is initiated by the primary care provider. Next slide. And this is statistics of living your best life. This information is from April of 2022 to September 8th of 2022. We have 111 patients enrolled in the program, with 72.9% achieving blood pressure control. And as you can see here, it gives us an average of the systolic and an average of the diastolic blood pressure, and our percentage of the patients under control. Next slide, please. And then this next one is the statistics for 60 days. So as you can see, within 60 days, the patients that are achieving blood pressure control are 85%. So these are the patients that are actively tracking their blood pressures and actively controlling their blood pressures. So, and next slide. All right, that is it. If you have any questions, we'll be here for the Q&A session. Thank you.
Thank you, Ruby, and so grateful for all of the amazing work that you all are doing. And I am going to ask Ms. Lisa to join us, and we're going to have a little panel really quick. Awesome, awesome. Well, just a reminder to all of our attendees, please feel free to put any questions you might have in the chat or in the Q&A, whichever is easiest. We are watching both of them. But wanted to kind of start with a question for both Ruby and Miss Lisa. Feel free to answer, whoever wants to go first. I'm not gonna start a line here. So I think whoever wants to go first would love to know, you both have this team-based care approach and a group approach, which is phenomenal. And I'd love to know if you feel that since implementing that, if you have seen improvement in your patient engagement, and if you have, what has that looked like in your health center? Miss Lisa, you're off mute, so I'll let you go first.
Okay. So we have seen an increased patient engagement. One of the things, if you noticed on my chart, the patient is part of the team. So when we do team-based care, that patient is probably the most important member of the team. It's really built around the changes they want to make, as opposed to us telling them what changes to make. It's what do they want to do? So I would say we have definitely seen more engagement, more interest in taking care of themselves. living a healthier life, changing their lifestyle.
Wonderful. Thank you. Ruby, anything that you've seen from a patient engagement, or Carmen, anything y'all have seen from a patient engagement standpoint from your team-based care approach?
Yes, it does make a difference, especially when they first referred, and when we make the first contact with them. We make them feel that they are, as we provide in this individualized care plan for them, they really engage. They want to be part of this journey, and we I do almost weekly checks on them with a phone call, just to see how they're doing, if that's possible at the time, depending on staffing as well, of course. But I think that having that contact with them and the communication, it does encourage them to participate and keep focused on what the goals are. And the goals are obviously to lower those numbers for them, eat healthier, keep active, lower stress, and the list can go on, but we definitely address each one of those.
That's wonderful. That's wonderful. Thank you both. And all three of you, thank you for your thoughts on that. And just love that patient engagement piece, because if they aren't bought in, then you can have as many phone calls as possible, but if they don't see themselves as part of that dialogue, then it is hard for them to really make the adjustments that they need. I've got a couple of questions around the fact that the place we are sitting in right now, September 2022, is very different than where we were sitting 3 years ago, where we all are very aware of that. Our clinics look different, how we engage with our patients look different. So my first question on that, I'd love to know how you were able, because both clinics are both clinical systems that you all are in, utilize technology. I would love to know how your utilization of technology with your patients, how does it look different now than it did before, and how has that helped or not helped in how you've been able to operate your programs?
Well, I think having in our case, in our clinic, doing virtual visits, connecting with them via, virtually, it does help a lot. Let's say a patient has recently been diagnosed or is diagnosed with COVID, or is not feeling well to be able to come to the clinic. Yes, connecting with them virtually has helped a lot, for sure.
Wonderful, thanks.
Yes, I think we've seen the same thing. Like when we before COVID, our patients did not want to do telemed visits at all. And the last 2 years now, we keep them for sick visits and other things. And some of them prefer it. They can do a visit while they're, on break for lunch or something. And so the big thing I noticed too is because so many of our patients had a home blood pressure monitor, that during COVID, they could actually take their blood pressure for that telemed visit and give us the reading. I know that's not the same as being in the office and doing it, but it did help us. It really got us through that year and a half when we couldn't always see people consistently in the office.
Yes, it's amazing how much more used to technology we are now, much more comfortable we are with it, including taking your blood pressure at home, which is certainly something that we I know are working to do with our clinical partners all across Texas, many of whom are on this call. Just what a benefit it is. I know, as a mom of 3, telemed visits, Ms. Lisa, to your point, are often easier for me to juggle, in putting in. So I think I'm much more likely to be able to actually make my appointment and be on time for it when it is on technology or technology based. So similar question, kind of thinking about the times that we are in, we know that clinics are stretched thin right now, that there have been a lot of staffing challenges. But you all are still offering amazing services, wraparound services to your patients. Could you talk a little bit about how you've been able to continue those services, even with the challenges that we face on a variety of different levels at your clinic sites? Miss Lisa, I'll let you go first.
Yeah, so, we make it because it's a priority. I mean, having, if you talk to our physician and our medical director, having that registered dietitian in our clinic is probably makes one of the biggest impacts, along with the behavioral health specialist. I think our challenge, honestly, has been, because we have a lot of patients that speak Spanish, so we want bilingual, and we've been fortunate to have that, but it's been harder to find. And so I feel like that is the big challenge, is to really, make sure we have those language appropriate, staff and resources, but it's our priority. I mean, it is, I'll cut almost anything. The clinical staff, the team that takes care of our patients, we would not get these outcomes if we did not have it.
Thank you, Miss Lisa. Ruby or Carmen?
Well, for us, I guess we have been, staffing has been an issue for us in the last few months, but we're working on it to staff accordingly. But we do our best to I don't want to say prioritize, but every patient is important. But as the referrals come in from our providers, depending on their let's say diabetic with hypertension or hypertension with diabetes, we try to reach out to them as soon as possible. We put them on the schedule. My other colleague, educator, we communicate a lot. I mean, sometimes we stay late, we come early. So we try to do the best we can with what we have. But thank goodness we count with the support of other co-workers here. And so to be able to reach out and take care of our patients. But our staff here is trying to get enough, actually, how can I say enough? Well, actually there is a, another way of helping these patients, not only because our pharmacist is also available to answer questions when we need it, and they reply, our providers as well, they support us that way when we send them questions. And so by the prompt reply, we're able to assist the patient in many other ways than just seeing them one-on-one or just over the phone. But we're looking forward to having enough staff here to better provide our patients with what they need.
Thank you.
Can I add one thing on that?
Absolutely, absolutely.
One of the things we do too is we have a lot of relationships with some of the local universities. So like for nurse practitioners, they precept here, and we have hired, from that. The same thing on the RD, there are lots of preceptor programs. Mental health, we work. So that is also a way that has helped us. It's very hard to find staff right now. I'm right there.
It is hard.
I'm right there with you, but that has been something that's helped us.
And that's a great idea. Thank you for sharing that. But also, one of our other, if we're talking about challenges, I think one of our challenges today, and we were talking about technology as well. I think with a lot of our patients are also Spanish speaking, uninsured, and they're older patients, and they're kind of find that trying to connect with certain technology, it's a big challenge. We kind of have to take them by the hand and guide them through it, and that takes a lot of more time. We, of course, because we deal with one patient at a time, but we got to be patient and do whatever it takes. But we find that a combination of technology and not being able to communicate in their own language. Sometimes, I mean, I am bilingual, and also the other educator is bilingual, but still it's technology for them, it can be a challenge. Sometimes transportation is a challenge for them to get to the office. So many factors play into it. So, but we have to tackle those and face that, and again, kind of work around all of that in order to get the patient focused on what we need to, the goals that we need to to meet, but we always set realistic goals, and that's the key.
That is some wonderful advice. So much so that I'm going to keep asking you for your advice a little bit. Want to ask, and Ms. Lisa, you kind of just addressed this, and so I want to go to you. I'll go to you first to see if you have any additional suggestions. But when we're talking to clinics who are tight staff, short staffed, having those challenges, but they're trying to do team-based care, what would you say to them, as they're approaching this, they recognize the need to do it. What would your advice be to, a clinic that might be stretched thin on how to best approach team-based care?
Yes, I mean, it's hard, right? I've talked to other clinics. Maybe you don't need to spend 30 minutes. Maybe you start with trying to do 10 to 15. For us, it really does. We have 2 clinics and 3 providers, so it takes the full 30. But I would say start by having a team meeting. Whatever time works for you, whether it's first thing in the morning, which is what we do before we start, or if it's after lunch, or at the end of the day, start with that. Identify what your priorities are. What do you want to accomplish on that team meeting? For us, like, we try to look at the patients coming in the day before, and we put a little code in the chief complaint, AHA, which means, hey, there is either their blood pressure is not normal, and we want to make sure they're participating in our hypertension algorithm. So I would say decide what you want to do in that, right? And then make sure people have some time carved out to identify those patients, ideally the day before. So when you get in that meeting, it goes quickly. And I would also tell you, when we first started, it took us at least 6 months. Like, we weren't sure, how does this work? And somebody, a doctor who is more experienced than I am, said, oh, that's all? So you have to be prepared to stick with it, and eventually it becomes, that muscle memory. And you start to see the staff share information about a patient, and it gets better. So don't just try it for a week or 2 and give up. And I would say also identify those patients you really want to focus on, whether it's your uncontrolled, or do you want to focus on those that you're trying to, the elevated stage 1, try to decide what that target is.
So I like that idea of having a huddle and addressing certain or focusing on certain patients, discussing patients. So when you have if I may ask you, Lisa, after you have the huddle and the patient is seen, who follows up on those patients that you discussed on that particular huddle for that day?
Yes. So our huddle used to be in person, and then when COVID hit, we did Zoom, and now we just do Teams. So everybody, no matter where they are, they're on it, and the provider shares the screen of all the patients coming in. That's kind of the format of it. So everybody's there, they're all on looking at it. There are assigned responsibilities. The medical assistants, for example, and nurses are really big on ours for making sure, for example, if that patient's got to get a blood pressure monitor, or if that patient, we need to see their readings or their log, they know, because when that chief complaint, there'll be that AHA code. And that signals to them, oh, this patient's coming, and they know, okay, I need to make sure, I check that blood pressure too. And they let the provider know, hey, what's going on with the reading, since, and obviously the providers look at it, but they kind of give the provider the heads up. They also can do warm handoffs to the registered dietitian or whoever's doing your education. We used to ask if they wanted that. We don't ask anymore. We say your next stop is before you leave. And if they're available, we walk them down. So the dietitian usually is the one who looks at them the day before and puts those codes in. And then the medical assistant will assume responsibility when they check the patient in. And from there, they kind of know they have to navigate that patient to the physician, whether they have to be trained, to the RD. That's kind of how that works. Did I answer your question?
I like that. I really like that. That model.
Yeah, I will tell you, if you ever start doing a quick huddle, you'll never stop. And I know everyone says we don't have time, but I promise you start, you'll never stop, because it just adds so much benefit to staff and the patients.
And the best time to do that is before starting clinic, or is there a best time for you that you do that?
So our staff gets here at 8:30. Technically, the meeting starts at 8:30, more like 8:35. Okay, but 8:30 is, and everybody should be on except the people answering the phones. Front desk people don't join that call because they're busy with the phones. We start seeing patients at 9. So, you can make it as short, sometimes we're done in 15 minutes, sometimes it's 30. But I would say do what works with your staff and your team, because everybody's team comes in at different times. But the important thing is just to do it. Some people I know do 15 in the morning and then 15 right after lunch. I've heard of that. We don't do it that way, but I've known clinics that have done that.
Yeah, because having multiple doctors, multiple providers, at different schedules, same day at the same clinic, it can be, yeah.
Yes.
So, well, thank you for sharing that, and I really like that idea.
I mean, you're starting to drive this car on our road trip without me. I'm fascinated by the questions you're asking. So thank you. I have one for you, Carmen, and very similar to the one that I asked Ms. Lisa. And however, it's very similar. So I'll just stick with that. But if you were talking to a clinic that is hearing you right now and is bought in, they're ready to go with these wonderful programs that you all are doing, what advice might you give them on starting out? How do they start getting their hypertension care, just trying to improve it a little bit? Where would you suggest that they first look at, if they're not doing anything right now, to kind of start down the road of getting to where you are now?
Well, I think that comes with getting together with either the provider, the medical, the CMO, coming up with all agreeing that this is going to be implemented, and of course having either a CHW or a nurse on staff to put this plan together and execute it. But I think it starts with the communication with the provider, sending those referrals in the plan of care, and then meeting one-on-one with the patient. Like in our case, we meet with them for about an hour. We ask a number of questions that range from their social habits, their social life, their eating habits, their physical activity. And so we discuss medications, not necessarily, I mean, we know our scope of practice, and we only, with that in mind, but any concerns, anything that comes out of the meeting, we relay that to the provider. But I think it's just building that trust with the patient so they can connect with you. I think that that's very, very important, to the point where they can actually will be calling you. I had a patient who just called to say, hey, I'm doing great, and no concerns, just to say, hey, I'm doing well. I said that's wonderful. So it was good to say hi, and that was a 2-minute call, but it was just wonderful. And it's good to build that good rapport with them, and that they can trust you and can call anytime, and we're here for them. But it's communication between the staff, the office, and executing the plan. But obviously, there are resources available, and of course, the American Heart Association is there for us. It's just such a wonderful resource.
I love that. Building relationships is so key and important in everything, because when patients trust you, they feel like they can tell you anything, and even just call to say hi. Carmen, that must have been nice. There was no emergency
wonderful.
needed. It was just a little hello.
Yes.
That's wonderful. Well, we are nearing our end time today for the panel. So I wanted to just give you all, another moment or two, if there was anything additional you wanted to add. We've got a lot of other clinicians on the chat and in this call. I know that we're all facing similar barriers, with staffing, but maybe also some different ones. Just would love, something to end on upbeat. You've got amazing programs. Is there anything that was surprising to you, or something just phenomenal that you saw as a result of these, that you just kind of keep close to you in the hard times, that you remember the amazing outcome that you were able to get to? As we have some people that might be listening that are ready to go and ready to start this. Maybe, Miss Lisa, to your point, they've been doing it, they're on month 3 and they need some encouragement. So anything you have to kind of, that's just been an amazing outcome from the programs that you've been able to implement.
Well, I kind of piggybacking off what you said about that patient who just called to say there was nothing wrong. I think for us, it's just been the most surprising thing is our patients really embraced being empowered to, do something about their health, to reduce their risk for heart disease and, to be healthier. And so for me, it's been, we're not just giving them, we do give prescriptions, okay, but it's more than just handing a prescription and having those relationships. You see them, they come in, they're feeling good. And, and their mental health seems better. So I would just say for us, it's just seeing the overall impact. It works. Our patients are living a healthier life. And, I think as healthcare providers, that's one of the most rewarding things is you see people are actually getting healthier and living a better quality of life.
That's wonderful. Carmen, anything to add to that?
No, it's just very rewarding. It makes me feel good. It makes my day to know that we can have that impact on someone, and we're here for them. Nothing pleases me more than to see like the one patient that called. It says after implementing, changing their diet, eating healthier, keeping active, even their mental health improved. It's just wonderful to see that change. And that's motivating to go on. Yes.
That's amazing. Well, I truly am grateful for the work that you all do, and that I get to work with you, that Bree and Norma on my team get to work with you. We're grateful to have such wonderful clinical partners. So thank you all for your time and what you shared today. We are gonna have one more pit stop on our road trip today, and we're going to hear some clinical best practices and get an update from Dr. Kate Curley. So Dr. Curley, I am going to hand the steering wheel over to you.
Thank you so much. I love being thought of as a pit stop. That's fantastic. And I'll also say, this is a tough act to follow because there were so many great ideas, so much great work happening from our panelists that there are things I plan on stealing and taking back to my work here at the AMA. But by way of quick introduction, I'm Kate. I'm a family physician. I'm Director of Chronic Disease Prevention and Programs at the AMA and have worked with healthcare organizations on improving their blood pressure control for a long time. And AMA is really happy to be a partner in this series. But we can go on to the next slide and I'll dive right in. So my job here today is to give you, a quick update, a quick snapshot on, what's cutting edge, what's high priority in blood pressure care these days. If you have been on previous Texas hypertension summits or Target BP webinars, you have probably seen this MAP framework before. But just in case, let me talk about it for 1 second. This is the framework that our organizations use when we work with healthcare organizations to help them improve their blood pressure related quality of care. I would actually say this framework is helpful for any kind of chronic disease or chronic disease prevention related quality improvement. But just to run through what this means, the M in MAP is about measuring accurately. So making sure that we get these accurate blood pressures to base our clinical decision making off of. It's crucially important in blood pressure care. A is about acting rapidly. So making sure that we take action after we diagnose hypertension or we identify that somebody has uncontrolled high blood pressure, making sure we get our patients the right treatments when they need it and really working to overcome therapeutic inertia. Most of what I talk about now for the next few minutes is really going to be about this act rapidly piece. But also just to tell you about P in the MAP framework, this is about partnering with patients. really supporting them to self-manage their condition and adhere to their treatment plans. And I think what we've heard about so far has had so many great ideas that really cross all of these areas, but especially that partner with patients piece. So I'm gonna change the topic a little bit and really focus on how do we address therapeutic inertia? How do we make sure that we intensify treatment for our patients with uncontrolled blood pressure when we ought to be intensifying our treatments? So let's move on to the next slide. So before I talk about how to intensify treatment, let's talk about when we should intensify treatment. Now I've stolen this slide from Dr. Keith Ferdinand, and he created this slide really to talk about when we should be initiating treatment and when we should be intensifying treatment for our patients. So this comes from the ACC AHA hypertension guideline. And if you look there, when you see the BP threshold, that's the level at which we want to initiate treatment for our patients, specifically pharmacological treatment for our patients, if they cross above that level. And then if you look at the column that says BP goal, this is the blood pressure level we are trying to get our patients below when we treat them with medications. And so you can see for many of our patients, especially our high risk patients, people with clinical CVD, especially our people with a 10-year calculated ASCVD risk that's 10% or greater, both our threshold and our goal are going to be 130/80. Now for our patients who are a little lower risk, they don't have clinical CVD, they have a lower calculated 10-year ASCVD risk, their threshold for initiating medications can be 140/90. But when we do treat them, we still want to treat them down to a goal of less than 130/80. And then if you go to the next slide, you can see that for our patients who have comorbidities, we have very similar goals. So for our patients who have diabetes, chronic kidney disease, et cetera, our threshold for initiating treatment should be 130/80. And our goal that we want to treat them down to is less than 130/80. The only real exception here is for our patients who need secondary stroke prevention. Our threshold for pharmacologic treatment can be 140/90. But again, 130/80 is really what we want to think about as our goal for treatment for most of our patients. Next slide. And when we think about, achieving that goal, there's a lot of strategies we could put into place to try to achieve blood pressure control with our patients. This study, I think, is really interesting, though, because it gives us an idea through a modeling approach about just how important it is to make sure that we intensify treatment when it's indicated for our patients. We're actually not great about this. When our patients see us and they have uncontrolled hypertension, on average, around the country, we intensify their blood pressure treatment 13–15% of the time. So the vast majority of the time that patients are seeing us with uncontrolled high blood pressure, we're actually not intensifying their treatment at those visits. So this group of researchers kind of modeled this out. They said, what if we did better at intensifying treatment more frequently? They said, let's imagine a population based on NHANES data that has a starting blood pressure control rate of about 46%. So not a wonderful blood pressure control rate. They said, what if we could do better with intensifying treatment more frequently? What if we intensified treatment 62% of the time when patients came in with high blood pressure or uncontrolled blood pressure? What they saw was that if we could get up to that rate of treatment intensification, we would expect to see a blood pressure control rate of greater than 80% in this population. Now, for comparison, let's say we instead focused on medication adherence. Let's say we focused on making medication adherence perfect with our patients, achieving a med adherence rate of 100%. That would only be expected to improve the blood pressure control rate to about 57%. So intensifying treatment is probably our single most important strategy that we want to focus on when we think about addressing low blood pressure control rates. Next slide. So when we think about how do we really systematize treatment intensification, how do we just generally do better with intensifying treatment when it's needed and overcoming therapeutic inertia, overcoming that tendency to not improve our treatment or increase our treatment when it's indicated? There are a few strategies that I would recommend that you all focus on. The first is using more single pill combination medications. The second is using a treatment protocol, and the third is making sure people have frequent follow-up until their blood pressure control is achieved. So let's talk about each of those in a little bit more detail. Next slide. We'll first talk about combination therapy. So combo therapy means having a patient on more than one class of blood pressure medication at the same time. In comparison, monotherapy means just using one class of blood pressure medication. Now, most of our patients with uncontrolled blood pressure will need combination therapy. They will need more than one class of medication to reach their blood pressure goal. A relatively small percentage can get away with just a single class of medication. So we want to get them there faster. Also, if you find that you have a patient with uncontrolled blood pressure and you need to titrate their medications, adding a new medication class at half the standard dose has 80% of the blood pressure lowering effect of a full dose. So I think that's not intuitive at all, right? You would think that if you add a medication at half standard dose, you would see about half the blood pressure lowering effect of the standard dose. But in fact, you see 80%. You see most of the blood pressure lowering effect by just adding half a standard dose. And you tend to have fewer side effects for your patients. So we do really want to think about adding more classes and working with potentially lower doses to get people's blood pressure under control. So if you go on to my next slide, my first take-home message for you is when intensifying treatment for high blood pressure, adding a new medication class is more effective at reducing blood pressure compared to monotherapy, or compared to just kind of titrating up that existing medication. So add a class. That's the take home. Next slide. Now let's talk a little bit more about single pill combos. Let's also talk about initiating treatment. When I say single pill combination, I mean a pill that contains two different classes of blood pressure medication. So for example, a pill that contains lisinopril and hydrochlorothiazide, that would be a single pill combination. The current guidelines say that when we initiate antihypertensive therapy, we should do so with two first-line agents of different classes. And we can do it either as separate agents or in a fixed dose combination. And this is recommended for adults with stage 2 hypertension and an average BP of greater than 20 millimeters of mercury systolic or 10 millimeters of mercury diastolic above their BP target. This basically means anybody with a blood pressure greater than 150 systolic or 90 diastolic. So for all of these patients, we want to make sure that they are on at least two classes of medications. And I would suggest that you go the single pill combination route for the following reasons. Next slide. So with single pill combinations, we know that they help patients lower their blood pressure and reach their goal faster. And time matters here, right? Time is heart, time is brain. So we don't really want to spend a really long time getting our patients' blood pressure under control. Time is a sensitive issue with high blood pressure. Additionally, a reason to use single pill combinations is that they can help adherence compared to using multiple different pills. Also, if we use lower doses of our single pill combinations, we tend to reduce adverse effects for patients. And they're available. I find a lot of providers, care teams worry about, whether they'll be able to get these for their patients, but they're on Medicaid and 340B formularies. They're available through discount programs. Sometimes it takes a little bit of homework to figure out sort of what you have to work with sort of in your area as well as for your patient populations. But generally speaking, single pill combinations are quite available for our patients. Next slide. So my next take home for you is initiating treatment with two medications at low to standard doses is more effective at reducing BP and getting blood pressure to goal than monotherapy with fewer side effects. So lots of push here to use more combination therapy with our patients. Next slide. So now let's move on to our next strategy for addressing therapeutic inertia and really making sure that we intensify treatment when we ought to. Next recommendation is to use this treatment protocol. This is a great piece to implement to support team-based care as well. We've heard team-based care as a theme today. A treatment protocol is a really important foundation for doing team-based care well. Next slide. So benefits of using a treatment protocol, it really supports the providers at the point of care. You know, it makes treatment decision-making a little bit less complicated, a little bit easier. So you want to make sure that the prescribers have access to that treatment protocol at the point of care. You know, whether that's a piece of paper that's sitting in the room versus something that's built into your EHR, it's up to you, but you want to make sure they have access to it to make their treatment decisions a little bit easier with their patients. Really, I think the single most important benefit of a treatment protocol is that it provides the whole care team with that playbook. So we're all on the same page. We know which patients we're focused on, what treatments we recommend next for them, when they should be following up. All of those pieces can be outlined in your treatment protocol. And again, it provides that playbook for everybody to work off of. And it really serves as part of a multi-pronged systematic approach to improve blood pressure control. Very well studied. Next slide. If you want to make your own treatment protocol, there are some examples out there that you can use. You can kind of take them as is, or you can take a look at them and adapt them for your own site. I put the link in there for the Million Hearts webpage, which has a few different examples that you can take a look at. But in general, you know, your components of your treatment protocol are, again, who are you focused on? What are you going to do with them and when, basically? And so again, I really encourage everybody to take a look and start developing their treatment protocol. When you go about creating your own, you want to make sure you involve all your key stakeholders. So make sure your providers have the opportunity to weigh in. If you've got a clinical pharmacist on your team, this is a great exercise to involve them in. Really get all of your team involved in thinking about this treatment protocol so you can get buy-in. Next slide. So my third take home for you, a treatment protocol can help increase the use of evidence-based treatments for patients with high blood pressure. Super important. Next slide. Last little piece, little update for me to share with you when we think about treatment intensification and therapeutic inertia is really frequent follow-up. You want to have patients coming back frequently. It really feeds into your ability to achieve treatment control or blood pressure control. Next slide. The current guideline tells us that for adults initiating a new or adjusted drug regimen, so whether they just got started on treatment or they recently had their treatment changed, they should have a follow-up evaluation for both adherence and response to their treatment at monthly intervals. And I would say at least monthly intervals. You can even have them come back a little bit sooner if you want. You don't want to let them go out and wander around much longer than a month until you follow up with them again. Next slide. And as you think about how to do frequent follow-up, this is a place where you can also think about integrating self-measured blood pressure. So normally self-measured blood pressure is done by the patient measuring their blood pressure at home, or home blood pressure measurement. It allows providers to diagnose and manage hypertension more effectively. So it can both be used to confirm a diagnosis of hypertension, but it's also very helpful to inform titration of medications. And it's really a recommended strategy for patients with high blood pressure. It should be used in conjunction with counseling and guidance from the care team. It's very important to make sure that those home blood pressure measurements do make their way back to the care team so they can be used for decision making. But it's a very helpful strategy. It can help improve medication adherence, and it really helps patients better self-manage their high blood pressure. Next slide. So if you want to think about how you can integrate self-measured blood pressure as part of your follow-up strategy or your follow-up approach, here's just one example of how you can do it. So let's imagine that our patient comes in, they have their blood pressure that's above their treatment goal, their average blood pressure, and you make this decision to intensify treatment, right? You're following your treatment algorithm, they're going to intensify their treatment, and they go home. They hopefully fill their new medication. They initiate their new medication regimen. And we let them do this, take their new medication regimen for about 3 weeks. Ideally, at that point, we want to have them complete a week's worth of self-measured blood pressure readings. So the protocol that we want people to follow is 2 measurements in the morning and 2 measurements in the evening. We want to make sure that our patients are trained to measure their blood pressure properly. I heard some examples of how that's done earlier today. Really important that the patient knows how to measure properly. And ideally, we want them to do the week of measurements at home. but we'll take 3 days if we can get them. And then we want to make sure they communicate their readings back to the clinical team. The clinical team is going to average all of those readings. And that blood pressure average is what we want to use for our decision making at this point. And then we need to figure out how we're going to follow up with our patients. Could be a telephone or video visit, could be an in-person visit, could be asynchronous communication that you've planned for through your patient portal. But once you've done, you've reviewed that average SMBP reading and you've determined if you need to adjust treatment or not, you want to make sure you communicate that plan for your patient and then continue to arrange appropriate follow-up. And, you know, rinse, repeat this cycle until you get your patient controlled. Next slide. So my last take home for you is that frequent follow-up is very crucial. It supports improved treatment intensification and really use any modality that's available to you. You can be creative. So in-person, virtual follow-up, incorporating SMBP or not, other strategies that you might have as well. Next slide. So just a quick summary for you when we are thinking about really being on top of treatment intensification. The key strategies to think about are single pill combinations, using that treatment protocol, and having our patients follow up frequently until their blood pressure is controlled. And there I just have those take-home messages that we talked about throughout this portion of the presentation. And I think with that, I can hand it back to Jenny.
Thank you, Dr. Curley. I sincerely apologize because I did not read your bio before you started speaking. So we're going to go in reverse and we're going to read it now because you got to hear that amazing clinical practice update from Dr. Kate Curley, who is the Director of Chronic Disease Prevention and Programs in the Improving Health Outcomes Group at the American Medical Association. She serves as a clinical lead on the AMA's chronic disease prevention initiatives and leads efforts to advance chronic disease prevention via utilization of digital health solutions and improving medical education. Prior to joining the AMA, she was a practicing family physician and health services researcher at North Shore University Health System and a local clinic and a clinical assistant professor in the Department of Family Medicine at the University of Chicago. Thank you, Dr. Curley. And I'm so sorry to have completely gone out of order on that one. But we are so very grateful for your overview of these very important clinical recommendations. So I want to thank you all for joining us on this leg of the road trip around Texas. Please be sure to join us for the rest of our journey around this great large state. The registration link is going to be included in the chat box as well as in a few other places, I believe, that you'll be able to see on the screen. We want to send a special thank you to our amazing planning committee who made this trip around Texas and certainly this first leg across North Texas possible. So thank you to the amazing planning team and these amazing individuals. Again, we appreciate you joining us today for this wonderful presentation and being able to hear from our amazing presenters. Thank you for taking the time to listen in and to join in and to participate in the chat box and ask questions. We are so grateful for your time. Thank you all, and we will see you in October.
Thank you.
Thank you.
Thank you.